So the next complication of prematurity that we are going to discuss today is retinopathy of prematurity. Now the name itself suggests that it is something to do with the retina of the premature neonate. So what exactly happens in this condition? Now this condition was formerly known as retrolental fibroplasia, and later the cause was found to be hyperoxemia, that is too much of oxygen when given to the neonate, that leads to this condition of retinopathy of prematurity. And after the cause was discovered, there was decrease in the frequency of this particular disease. But now, since the survival rates of extremely preterm neonates has improved, it is for this reason that the frequency of retinopathy of prematurity is also increasing now. What is the pathophysiology behind this particular problem? Now, when the infant is intrauterine, from the 4th month till shortly after birth, if you can see, if this is the optic nerve, vascularization of the retina, the fetal retina, from the 4th month till shortly after, this after is very important, shortly after birth, there is centrifugal vascularization of the fetal retina from the optic nerve. So it starts like from the nerve and goes outwards. Now suppose when the neonate is born, the preterm neonate is born, and at birth there is too much exposure to oxygen, there is severe retinal vasoconstriction. So these blood vessels, they tend to constrict, and apart from that there is also endothelial damage to these blood vessels. So vasoconstriction leading to endothelial damage, this leads to obliteration of the blood vessels. Now when there is obliteration of the blood vessels, we always know that there is neovascularization. The blood vessel tries to find its way out through the blocked path. So there is aberrant neovascularization, the blood vessel tends to reform, but these are aberrant vessels, because of which they tend to penetrate from the retina into the vitreous humor. So it spreads into the vitreous humor. These are aberrant blood vessels, so they will lead to leak of proteins, they can burst at times, they can bleed at times. So these things are possible, and since there is bursting, bleeding and leakage of protein, there is formation of adhesions, and this adhesion leads to retinal detachment. So this is basically the pathophysiology behind the retinopathy of prematurity. Now, even in normal cases, oxygen after the baby is born, outside the womb, it is a case of relative hyperoxia anyways to the infant. So that threshold of exposure to the neonate, that threshold of oxygen that will lead to this particular condition is yet to be discovered, but a study was done to better understand the oxygen saturation threshold that is necessary to minimize the retinopathy of prematurity without raising the other adverse outcomes that can happen if you reduce the oxygen saturation. So support study was done where a randomized trial of oxygenation was done in 1316 neonates born between 24 to 27 weeks. So definitely it's preterm. So this was done in the NICU. One arm of the neonates were maintained at a target saturation of 85 to 89, and the other arm was maintained at a target saturation of 91 to 95. Now, it was found that deaths of the preterm neonates in the lower oxygen saturation group was significantly more. But those infants who survived out of the two arms, it was found that severe retinopathy of prematurity was significantly lower in those infants who were in the target group of lower oxygen saturation. So, this is a study that was done, but still there is no clear cut guideline as to what exactly is the saturation which is to be maintained to control this particular problem. And one more important thing I would want to share, vascular endothelial growth factor, which is needed for in the body for normal angiogenesis. It has been found that it is upregulated in patients with retinopathy of prematurity. So, antivascular endothelial growth factor drugs have been used in the treatment of retinopathy of prematurity.